Good morning, my dear students. Today's lecture is on respiratory failure, and this will be your last lecture in respiratory module. So, respiratory failure. So, what do you understand by respiratory failure? Any failure means inability to perform a particular task. So, in a functional standing point, not the definitive definition, in a functional standing point for your working clinical situation, respiratory failure is inability of your respiratory system to meet the metabolic demands by your tissue. Your respiratory system unable to meet the respiratory demand. That means the oxygen requirement created by your own body tissue. If your respiratory system is failing maintaining that, your body is failing. So that is respiratory failure. And these are the objectives, the definition, the factors, the pathophysiological parameters, how they change. But as you all gone through the lecture series in the respiratory module, it is just going to be the summary of that. And then we'll be looking in the oxygen therapy, how we are giving oxygen and few other important points, which are more relevant to your clinical day-to-day practice. So what do you understand by respiratory failure? I explained. By definition, it is a syndrome in which the respiratory system fails in one or both of its gas exchanging functions. So what are the gas exchanging functions? One is oxygenation, taking the oxygen from the alveoli to the blood vessel. Other one is carbon dioxide elimination, sending the carbon dioxide in the blood vessel to the alveoli, then to the atmosphere. Due to an abnormality of any of the component of the respiratory system. If you just look into the respiration, we have air in the environment, oxygen. It is barometric pressure and the FiO2. The percentage of oxygen in that air is 0.21 or 21%. Then it has to travel through your nose. That is an active process. You have to take breath in. Your diaphragm has to contract and your intercostal muscle has to come out. Then you have to create a negative pressure inside your thoracic cavity. Then the air goes via your nose, then pharynx, larynx, trachea, bronchi, bronchioles, then into alveoli. So see the path. Then from the alveoli, it has to diffuse through the alveolar capillary membrane. Then the blood, it has to bind with hemoglobin. Then it has to carry throughout the body with the help of your heart, the pump cardiac output. Then at the cellular level, again, the hemoglobin bound oxygen has to release and diffuse to the cell, then reach mitochondria. Then it used for electron chain oxidation. See the total stages of stage the oxygen has to go one by one. If any of one of these pathways is affected, that will simply affect your respiratory target or task. Then it leads to respiratory failure. That is what this last line, due to an abnormality of any of the components of the respiratory system. So the respiratory system consists of the gas exchanging organ that you know, that's your lungs, and the ventilatory pump, your respiratory muscles. Either or both of which can fail and precipitate a respiratory failure. Okay? And also respiratory failure occurs when the pulmonary gas exchange is impaired due to result in hypoxemia or hypercapnia, or sometimes hypoxemia with or without hypercapnia. All the entities are possible. And when there is the problem in the pulmonary exchange, the gas exchange means you have to give oxygen and take carbon dioxide out of the body. So if you are not getting enough oxygen, that is hypoxia. If you are not able to wash out carbon dioxide, that is hypercarbia. Respiratory failure can occur either, that means if a failure occurs due to the problem occurs in any stage of the oxygen going through your body, it can end up in hypoxia or hypercapnia. So you should know this definition very well. Hypercarbia, everyone know the carbon dioxide level is increased in the blood. What is the difference between hypoxia and hypoxemia? Is very important. Hypoxia is low oxygen level in your tissue, at the tissue level. Hypoxemia is low oxygen level in your blood. So know the difference. Very important. And I told you the oxygen has to come through this respiratory pathway, then it has to diffuse and reach the cell. So any problem occur in any of the stages, it can lead to respiratory failure. Simply, so imagine there is a failure in ventilation. That means, so now you work out and tell me how your ventilation can affect it. Your respiratory center get affected. If it is not working, there is no ventilation. If the cervical nerve, your C3, 4, 5, they are the phrenic nerve. C3, 4, 5, I'm not sure what is the component of the, what is the nerve root of the phrenic nerve. You have to check it out. If there is an injury to the phrenic nerve, the diaphragm will not active. So you can't contract the diaphragm. So you cannot create a intra-negative pressure inside your thoracic cavity. If there's a problem in the neuromuscular junction, like autoimmune diseases, your muscles cannot contract. So you can't perform your ventilation at your level best. So the neurological disorders, neurological problems like this can cause respiratory failure. And the muscular problem, like if your muscles are not strength enough and there's a myopathy like myasthenia gravis or Guillain-Barré syndrome, you are unable to perform the ventilation up to the certain expected level. So when there is a low ventilation, less amount of oxygen is going in. So low oxygen is called hypoxia. As there is a less ventilation, less ventilated rate, you are unable to wash out carbon dioxide. So there is an increase in carbon dioxide. So hypercarbia. So those are the outcomes or result of respiratory failure. So these are the few causes. And if you are unable to maintain the airway due to a airway obstruction, laryngeal edema, laryngospasm, or if there any foreign body goes inside your mouth and block the airway, you cannot perform ventilation. The air is not going in. And if there's a flail chest in the chest wall abnormalities, or there's the air or blood or a kind of fluid effusion inside the pleural cavity, like pneumothorax, hemothorax, pleural effusion, the lungs cannot expand. So the ventilation cannot occur. And the abdominal compression due to the large tummy or obesity or ascites, you cannot perform ventilation up to a certain level. So these all will lead to respiratory failure. And that is failure to ventilate. Then we will see failure to oxygenate. Even though you get a good ventilation, the air in the alveoli has to diffuse to the through the alveolar capillary membrane to your blood. So if there's a diffusion abnormality like pulmonary fibrosis and interstitial lung diseases, it will eventually end up in respiratory failure. And if there's a ventilation perfusion mismatch or pathological shunt, physiological shunt up to a certain extent it is fine, but pathological shunt that will eventually end up in respiratory failure, like pulmonary embolism, lung collapse, atelectasis, consolidation. They will cause problem in the VQ. So there will be a VQ mismatch and it will end up in failure. So all these are the causes. You should know the causes of respiratory failure. If one component of that, the pathway, the lengthy pathway I mentioned earlier, if one component is affected, unless we rectify that, it will lead to respiratory failure. And usually, your body is have a ventilatory demand. It needs certain amount of oxygen for its survival. So body always, the respiratory system will comply for that. It will give, it will support it. Always ventilatory demand is balanced by ventilatory capacity. When there is sudden increase in the ventilator demand or decline in the ventilator capacity, it will end up in respiratory failure. Because I told earlier, in the functional point of view, the body's respiratory system is unable to meet the demand So metabolic demand of the tissue. So when there is an increased demand and your capacity to give or do more ventilation is not sufficient, there's a discrepancy between the demand and the supply. So that will lead to respiratory failure. So if respiratory failure is present, the partial pressure of oxygen is below 60 millimeter mercury or 8 kilopascal. You are supposed to know the value. Or the partial pressure of carbon dioxide is above 55 millimeter mercury. These are in your blood level. Okay. The respiratory failure simply can be divided into two types. Now listen very carefully. It's very important. There are two types of respiratory failure. Type 1 is the partial pressure of oxygen is low, but the partial pressure of carbon dioxide is normal or low. The type 2 failure, the partial pressure of oxygen is low, but partial pressure of carbon dioxide is high. So that is type 2. The type 1 failure, only partial arterial pressure of oxygen is low. Type 2 failure, partial pressure of oxygen is low and partial pressure of carbon dioxide is high. So the type 1 is an acute hypoxemic respiratory failure. Common causes are acute asthma, pneumonia, acute lung injury, pulmonary embolism, lung fibrosis. The hypoxemia is mainly due to right to left shunt or PQ mismatch. Type 2 failure is there is a insufficient to remove the volume of carbon dioxide being produced by tissue metabolism. So you are unable to, because usually your body there is a metabolism is going on. So the end product of metabolism is carbon dioxide. When you are unable to remove that, that is type 2 failure. So the causes may be you may unable to remove or wash out carbon dioxide due to one, reduced ventilatory effort, hypoventilation, or respiratory rate is low, or your muscles are not strong enough to perform ventilation. Number two, inability to overcome increased resistance to ventilation. There's a resistance. Imagine the increased surface tension. Okay? So there's a resistance. So you need to work hard to overcome that. But if you are failing to overcome that, again failure. Third thing is failure to compensate for an increase in dead space or carbon dioxide production. And finally, a combination of any of these factors. A few other causes, like I mentioned, Guillain-Barré, myasthenia gravis, depression of the respiratory center, mainly the morphine overdose, and there's the chest wall deformities, all causes. Deterioration in the mechanical properties of the lung or chest wall. There's a problem in your lung or chest wall. So your body, with the help of brain, will tend to increase work of breathing. So when there's an increase in the work of breathing, there's an increase in the oxygen consumption and there's an increase in the carbon dioxide production. So decrease in the oxygen level, increase in the carbon dioxide. So it will lead to respiratory failure. So we have to act at the correct time to rectify the problem. Okay. So type 1, type 2. So type 1 is hypoxemia, type 2 hypoxemia plus hypercapnia. And this what I have explained, just go through this, that can be asked in MCQ. Again, another classification of respiratory failure, acute versus chronic. In the acute, you will have increased carbon dioxide, so pH is drops like pneumonia and acute asthma. The chronic, because the pH is dropped, carbon dioxide acidity, for the compensation, bicarbonate is increased. So I have taught you acid-base balance. Okay, so this is just this lecture is just a summary of what you have been learned so far in the respiratory module. So any problem from the air to the tissue level, that may end up in respiratory failure. Meanwhile, not only these ventilation and oxygenation, circulatory failures, even though you have a good ventilation and diffusion, if the blood flow is not adequate, then you won't be able to carry enough or adequate oxygen to the tissue. So this, I think I have explained, and others also explained. The oxygen cascade. If any problem occurred with any of these, will lead to reduce oxygen level. Again, the diffusion is affected. That's a problem. If there's a more physiological shunt, then there's a problem. Then the alveolar gas equation, if not enough oxygen in the alveoli, again, that leads to hypoxia. And pathophysiology of low FiO2. If you are going on a high altitude, the FiO2 is low. If there's a hypoxic gas mixture, that means in the environment, if there is too much of carbon monoxide and carbon dioxide, oxygen level will be anyhow low. Okay. And when the air is flow through, if there's obstruction in the upper airway, the amount of oxygen reaching the lung is low. So failure to oxygenate adequately. So what are the causes for that? Hypoventilation, diffusion abnormalities like lung fibrosis, pulmonary edema, pathological shunt, lung collapse, atelectasis, consolidation, and dead space, pulmonary embolism. So these are causing some problem in the technical issues. So hypoventilation, if your central nervous system is depressed, your respiratory center is depressed. So the respiratory rate will be low. The respiratory muscles are paralyzed. They cannot perform good contraction. If there's a damage to the chest wall, and if there's a high resistance, and if you have a very morbid obesity, those will cause hypoventilation, and this hypoventilation eventually leads to hypoxia and respiratory failure. So this is the equation for the alveolar carbon dioxide. I think you by now this should be bread and butter for you all. Okay. So when there's a reduction in the PiO2, then there's a reduction in the alveolar oxygen, then everything is low. Then diffusion abnormalities, I have taught you fixed flow and everything. So if there's a problem in the diffusion, the amount of oxygen reaching your capillary is reduced. So again, hypoxia. So this I have explained very thoroughly. And the VQ mismatch. If there's a problem in the airway obstruction, the ventilation is no, but the perfusion is there. So the VQ is 0. Like upper airway obstruction. Here in the pulmonary embolism, there is no blood supply, but ventilation is there. So VQ is infinite. So these are problems. So you won't get good oxygenated blood. So you don't get enough oxygen to the tissue. So that is respiratory failure. And again, VQ mismatch. This should be you, every one of you should be able to draw this and draw this, because they will ask this in exams very commonly. And there's a shunt. So physiological shunt is normal, and if there's a pathological shunt, that causes the problem. So when we compare the oxygen dissociation curve with the shunt at the capillary level, that means pure oxygen, pure arterial blood, not mixed with the deoxygenated blood. So pure oxygenated blood and alveoli, they are similarly, the saturation is, oxygen content is top. But when the deoxygenated blood, the physiological shunt comes, there's the oxygen amount is little bit low compared to this. So this is the blood which is reaching the tissue. So imagine if you have the large shunt, that means large amount of deoxygenated blood. So the end product or the blood reaching your tissue is having very less oxygen. So on that situation, this point may be somewhere here. So that is how the shunt is affecting the oxygen dissociation curve. So intrapulmonary shunt and extrapulmonary shunt are there. This is how the dead space affect it. I believe you all know what is dead space. There are anatomical dead space, physiological dead space. You should know that. Okay. So the alveolar capillary interface destroyed in emphysema, and there's a reduced blood flow in congestive heart failure and pulmonary embolism, and in over-distended alveoli in IPPV, that is intermittent positive pressure ventilation. So in those conditions, your dead space is altered. Okay, then this is another interesting area. You should know zone 1, 2, and 3. These zones are just an imaginary zone, not anatomical zone. Okay, depends on the blood supply and the oxygen in the alveoli. It changed during the exercise. And there's a wonderful physiology. As a common SCQ, I think they will ask. And they might have covered in the separate lecture. So now we'll come, if there's a problem in the respiratory system and it leads to respiratory failure, how we are going to assess that? What you see on the patient? Because so far, what we have seen is which is not seen by our naked eye. Those happen inside your body. So how these respiratory failure is manifest? Okay, like the increased respiratory rate, the use of accessory muscles of respiration, intercostal recession, tachypnea, tachycardia, sweating, pulses, paradoxes, inability to speak, or unwillingness to lie flat. These are the clinical manifestations or clinical features you will be seen in a patient who is on respiratory failure. And agitation, asynchronous respiration, paradoxical respiration, sometimes you may observe, and rarely you might see a respiratory occurrence as well. So what are the investigations we will perform? Because you always do ABG if it is available to recognize the respiratory failure. Because the ABG will show you partial pressure of oxygen in the blood and partial pressure of carbon dioxide in the blood. So with the two values, we can decide whether it is type 1 respiratory failure or type 2 respiratory failure. Then the most sensitive clinical indicator is respiratory rate. The more the respiratory rate, the more the demand, the more the body use oxygen, the more the body produce carbon dioxide. Okay? It's a kind of vicious cycle. When you work harder, your respiratory muscles work harder. Again, there is a loss of oxygen. So again, they want to work harder to take more oxygen, but without taking more oxygen, the oxygen is utilized for the muscles activity. So again, hypoxia is become severe. Okay. And in the neuromuscular disease like Guillain-Barré and myasthenia gravis, the vital capacity decreases and altered. And FEV1, you know that, right? They might have told you. It is useful in assessment of patient with suffering from asthma or COPD. COPD is a common cause of type 2 respiratory failure. Acute asthma is common in type 1 respiratory failure. And monitoring. How we are going to monitor a patient? So to monitor the patient, there is pulse oximetry. There's a probe like things they put into your finger, and it's a digital way of measuring saturation. It will gives you a number in digits like 98 or 99 a normal person, and in the respiratory failure it may be reduced. And there's a ABG. In the ABG there is a ratio of partial pressure of oxygen divided by FiO2. This is one of the main indicator of the respiratory failure. And capnography, don't worry, that is a way to assess the carbon dioxide level in each expiration. So it will assess you breath by breath expiration level of carbon dioxide. And how to treat respiratory failure? Yeah. How to treat respiratory failure? The standard management of patient with respiratory failure includes you have to give supplemental oxygen through a patent airway. Okay. Treatment for distal airway obstruction. If there's obstruction, you have to remove that. You have to take measures to limit pulmonary edema. If there's secretion, you have to suck it out. And if there's ongoing infection, you have to treat that with empirical broad spectrum antibiotics. So oxygen therapy. Oxygen is a colorless, odorless, and tasteless gas, non-inflammable. It is not inflammable, but it accelerates combustion when the FiO2 is more than 23. So there are two ways of application of oxygen, normobaric, and that means the oxygen you are giving in a cylinder to the patient in the ward. Hyperbaric oxygen, the oxygen pressure is high. Like when you are treating few poisoning and the divers who are affected with some issues with the respiration. And the oxygen is comes in compressed gas cylinders and oxygen concentrators and oxygen tanks and lot of things are available in the hospital. So hypoxia, I think the hypoxia lecture is finished, and by now you know there are 4 kind of hypoxia or 4 types. And what are the types needed oxygen? You should know that. In oxygen therapy, what we do is in the type 1 respiratory failure, that is hypoxia only. So we will give oxygen, maintaining the saturation target should be 94 to 98%. In the type 2 respiratory failure, mainly in the COPD patient, you need to maintain the oxygen saturation by or between 88 to 92%. Why? This is one of the very important questions. Why in type 2 respiratory failure, your target saturation for oxygen is 88 to 92? Because when there is a reduction in oxygen or increase in carbon dioxide level, what will happen? We are now going to regulation. What receptors are affected? Central and peripheral chemoreceptors. When there is an increase in carbon dioxide, what is predominantly activated? Central. When there is a reduction in oxygen, what is predominantly activated? Peripheral chemoreceptors. Okay. So when there is a reduction in oxygen, these receptors are activated. But if you are giving more oxygen, what will happen? The hypoxia becomes settled. Your hypoxic drive is no more. But you are having increased carbon dioxide because this is COPD, type 2 respiratory failure. So you have to keep the carbon dioxide washed out as well. So you have to maintain your respiratory rate at a certain level. Meanwhile, maintaining your oxygen in the blood. That's why to keep your hypoxia drive, you are giving saturation of oxygen with the limit of 88 to 92%. Okay. So here I have, okay, I will read again. In type 2 respiratory failure, which is, listen very carefully, this is common SEQ question. The type 2 respiratory failure, which is characterized by hypercapnic and hypoxemia, maintaining oxygen saturation between 88 to 92 is often a clinical target. One is usual physiological response. In a patient with chronic hypercapnia in the COPD, their respiratory drive is primarily stimulated by high levels of carbon dioxide rather than low levels of oxygen. Giving high levels of supplemental oxygen can suppress their respiratory drive further, potentially leading to hyperventilation and worsening of hypercapnia. Administering high levels of oxygen can cause the patient's blood oxygen level to rise above normal. In patients with chronic hypercapnia, this is reduce their respiratory drive, that is hypoxic drive, which is essential for maintaining ventilation. As a result, their carbon dioxide level can further rise, leading to worsening of respiratory acidosis. So, you need the hypoxic drive to maintain respiratory rate to wash out carbon dioxide. So the goal of targeting oxygen saturation between 88 to 92 is to ensure adequate oxygenation while avoiding risk of suppressing respiratory drive and exacerbating hypercapnia. Okay. With that, our lecture comes to an end. And I wish you all the best for success in your first modular exam. Good luck. As I always tell you, every one of you is a champion. So we will pass the exam. Wish you all the best, my student. And as I always say, may peace be upon you. If you have any doubt or if you need any further explanation, you can always contact me via email or WhatsApp. Thank you. Have a nice day.